All right, guys, this is the second lecture for tonight. I apologize once again. I hate that we missed our in-class sessions. However, we are just going to go through this bleeding control. There's going to be more hands-on, as I said, with John whenever he comes in next Thursday to hopefully be able to facilitate you guys. That's going to be a day, unfortunately, I'll be working. So he will be taking lead, and he will go through all kinds of different bleeding control, tourniquet application, and such, okay? So this is a very important slide here because if we don't know how to control bleeding, how to stop bleeding, the person is essentially going to die, all right? So we need to have some key principles involved whenever we start assessing these patients. So first of all, we're going to go into what is bleeding? What is the management? That's pretty simple, right? We've all probably lost a little blood before, whether it be through a small scrape or through a major cut. Let's talk about the pathophysiology assessment and management of bleeding. We're going to go back through, once again, that A&P stuff all over again to be able to hopefully remember some of the key aspects, especially when we talk about the blood circulation. So we understand which side, if it's venous or arterial, those are big deals. One of which we can control with direct pressure. The other one may have to use direct pressure and other sources. So we'll discuss that in a little further detail. Yes, so pathophysiology, we need to have a good sense of the, it says respiration. I would be more inclined to cardiopulmonary, so let's do both of them, the respiration and the heart, okay? Those are two key aspects when we start talking about bleeding and bleeding control. So we need to have a good sense of recognizing a bleed, and we need to understand how that affects the body whenever it is at a great loss. And just remember, there are two different forms of it. You can be bleeding internally, or you can be bleeding externally. Externally stuff, we typically got pretty good. We can see that as long as you do your job. We'll talk about that a little later. But internal stuff, not so much, especially when we start talking about these high compartment areas, such as the pelvis and the femur and the abdominal cavity. That can hold quite a significant amount of blood, and we may not be able to notice that until we're at the hospital, or maybe we may not even see it at all. So just know that too much blood, we can't get back. It's going to cause weakness, shock, or even to the point of death. Okay. So let's hit that anatomy physiology right quick of the cardiovascular system. If you guys remember that the heart essentially circulates the blood, it has to go through the right atrium to the left or right ventricle, then out, and has to go through the lungs where it picks up carbon dioxide, or oxygen dumps off the carbon dioxide, goes in through the left atrium to the right atrium, and then left atrium to the left ventricle, and shoots out into the bloodstream where it's diffused across the organs, and it just keeps going on and on from there. So the biggest thing is that we have the oxygen nutrients, but on the other side of it, it needs to take away all that metabolic waste, which is typically in the form of CO2, but there are some other things beyond that. But typically what we see is carbon dioxide is being removed off the cells too. So the red blood cells are very important. Circulation is even more important, that we have to have that pumping as it should. If it doesn't, then we're going to start having some shocky situations. So remember the three parts. The pump is the heart, the container is the blood vessels, and then you have the fluid, which is the blood and the body fluids. Remember, the blood is, we'll talk about in a minute, I always get ahead of myself. The blood it's got more components than just the red stuff, okay? So if you guys recall, look at the way that circulates. It is always good to know how the blood flow is through the heart, especially for those of you who wish to go further into your studies, maybe become an advanced EMT or even a paramedic. You're going to see this quite a few times. So it's better to nail it down and have it hammered out. And there's usually some test questions somewhere in there, whether it be in this class or in the state, that will talk to you about blood flow. So have this key aspect already solidified in your head. So the heart, remember that the heart also has to have a blood supply too. We talked about heart attacks before, but there are coronary vessels and arteries that have to have blood flow supplied and feed that heart. Remember that there are two chambers. You have the upper chambers, which are the atrium, the lower chambers, which are the ventricles, of course divided into left and right by the septum in the center. So remember all these key aspects. What's weird about this is typically deoxygenated blood is known as veins. But when we talk about your pulmonary side of things, the deoxygenation is going to be your arteries, your pulmonary arteries. And likewise for the pulmonary veins, that's actually going to be oxygenated blood. So it is reversed. Only place in the whole body that those terms are different. It's weird, but that's the way it is. And remember that there are the flaps, the mitral valve, and the bicuspid valve, all those, and you have your the aorta valve, the pulmonary valve, all those that control the blood flow, keeps it from regurgitating and going back into places. And we could talk about that for a while, but I'm not going to hit that. We just wanted to get a brief overview of all this. So arteries. Arteries carry blood away from the heart. Know that it goes to areoles, and then it goes all the way to capillaries. Capillaries are where it links the venules and those arterioles together, and those that's where the diffusion of gases happen in the nutrients and such. Okay, the slowest cellular level. As I said, venules are the smallest version of veins. So they are very small, very thin wall for the air or the gases to exchange out in the nutrients. And then you have your veins, which are the larger vessels that go toward the heart. So arteries go away, vessels go to, our veins, excuse me, go to the heart. And which of the two carries the most pressure? I'll let you guys think about that for half a second. It's going to be arteries, okay? Arteries have a higher pressure. So when we start to talk about bleeding, those are a big deal, okay? How we're going to control those and how the pressure that we're going to apply to it, okay? So here's a slideshow. If you guys remember this, just look at, so the alveoli, which are the smallest sacs in the down in the bronchioles, very, very small, very finite. So essentially the vessels break off across the capillaries and inside the alveoli, and that's when the waste and the CO2 is dropped off and the nutrients and the oxygen is picked up. Okay, and you kind of see that, hopefully, that slide. I'm more of a visual learner, tactile and visual, so I like seeing these slides. It makes it a lot easier. Pause it if you need to. Try to refresh yourself. Okay, guys. Yeah, and if you see, sorry, I could break this down a little bit easier for you. So the yellow colored things you see in the upper right-hand corner of that picture, that's going to be your cells. Okay, it doesn't really say that there, but so cells are kind of exchanging there with the red blood cells, or the tissues, I should say, and things are diffusing and moving back and forth. Okay, RBCs, red blood cells. So red blood cells, essentially, they have that hemoglobin, and what attaches to it is either going to be oxygen or it's going to be carbon dioxide. And there's going to be a pressure exchange. I'm not going to go into crazy detail about that, but there's a pressure exchange inside of the lungs that causes that diffusion to where it exchanges off. So just know that that is the key principle for red blood cells. Hopefully you guys have that nailed down. If you don't, please learn it, okay? It's a big key issue. You need to know what white blood cells do and red blood cells do, okay? How those two differentiates. So white blood cells, speaking of which, they fight off infection. That's their job, okay? They go after anything that is possibly an infection. These are also the reason why sometimes we have cardiac coronary artery problems. It's because they perceive a threat and they start occluding things off, and then you block the whole vessel and then you have a heart attack. So they are also responsible for that too. Platelets are also, their job is to form blood clots. So essentially what they do, I wish I could go in greater detail. There's so much craziness to talk about. But the way that a clot forms is it starts with the platelets, and you have the fibrin, and eventually it works its way back to sealing it off completely. And eventually those cells die off and you have new skin. It's amazing how it works. So, and the other part of the blood contents is going to be the plasma. So think of that as the fluid in which it just kind of rides along with. Okay, that's kind of what it is. Some other issues that you got to really think about. So, how much blood is really in the person? We are walking usually around at least a liter low of fluid. And a lot of us don't drink enough water. I haven't done enough today. I know I haven't. But hydrate yourself, guys. I'll just tell you that too. Some other thing is changes in blood vessel walls. So as we get older, our vessels don't constrict and expand as they did when we were younger. So that's always a possibility. Somebody could be on medications that could hinder that also. The blood's ability to clot. We'll talk about those a little later about hemophilia and stuff. That will definitely keep a person from clotting as they should. So as I said before, whenever we have any type of injury, those plates, it's like, okay, let's do some work, and they come in, they do this cascading effect where they try to clot off, and hopefully the cut is small enough, or the bleeding is small enough to where they can do their job. Now, if it's a mass amount of blood, it's going to need external forces to keep that from continuing on. So, like I said, there's so many things that come into play when we talk about that. Autonomic nervous system, so your ANS, so it's automatic, right? So basically it adjusts and it tweaks things to reach that homeostasis, that balance of things. It may slow down the heart, it may speed it up, it may ask for more oxygen, therefore your respiratory rate goes up, the kidneys can control your blood pressure, slow it down a little bit, constrict things. All kinds of different stuff happen to this to try to offset the bleeding, try to control it. Know that, look at this picture right here, guys. When I talk about shunting blood, remember I talked to the one group. I didn't get to see you other guys, and we'll get there eventually. Shunting of blood. So whenever we are discussing the shunting, within these capillaries, the smallest capillaries, there are little valves, if you will, that will shut off the blood flow to go to more important organs such as the head, the chest, and the stomach. All this right here is very important. So in a shock situation, it tries to go to survival mode, and that's where it does. And that's why you have the skin especially is very, it's not as useful as the heart and lungs and the brain. So it'll take all that, and that's why you get that weird color and skin condition from that reason. But yeah, we know what perfusion is, right? Perfusion is adequate amount of blood flow to the organs. So hypoperfusion being low, hypo, low. Perfusion means that it's not doing what it's supposed to. It's not removing the waste. It's not getting oxygen. Those are the issues we see with there. So the speed of blood flow. So this is directly related to the amount, how good the heart squeezes and how well the vessels are working. And it should be good enough to where the blood cells can move through and exchange the gases like it's supposed to, and the nutrients and the waste. So it should be just enough to be able to push those through. And yeah, some tissues need a constant supply of blood, while others can survive with very little. Your skin, as I said, can do without much blood. Heart, not so much. Heart will die without blood flow. Brain also, same way. Those are very vital organs, as that's why the blood is shunted. Yeah, so we know this. I've hit this a couple of times. I'm not going to go back over it, guys. So this is some interesting numbers. I don't expect you guys to know this, but look at this. So brain and spinal cord last only 4 to 6 minutes without a blood supply. What? So we gotta get that shock management under control as quick as possible. Okay, gotta take care of that. Gotta stop that bleed. Lungs can survive 15 to 20 minutes. Right? What I tell you, the most vital organs are going to be the head and the chest. So the lungs, the heart, and the brain. Now kidneys can survive for 45 minutes. Now there might be some type of renal damage there, but they'll last that long. Skeletal muscles, 2 hours. They might have some lactic acid. There might be some issues with that. And these are based solely on normal body temperatures. Now listen, like I said, the body doesn't thermoregulate and the clotting factors don't happen. We need to keep them warm. The big deal, guys. A lot of people felt that. Hemorrhage. I still can't spell this word. Tell me if that ain't bad. I've been doing this for so long. I have to really think about it as I'm typing it. It's bad. So hemorrhage is bleeding. All right. So if you hear of internal hemorrhage or external hemorrhage, bleeding. That's all it is. External is easy to see. This also includes nosebleeds, so epistaxis. So remember, guys, that you are, as basics, can utilize Afrin spray for this. Okay, 2 squirts in the affected nose, and what it does is it vasoconstricts, shrinks the vessels that are bleeding, and hopefully stops the bleed. Now, listen, the issue with that is you have people on blood thinners who have cardiac history, or maybe they've had thrombosis before, embolisms. They may be on a blood thinner, and guess what? It's going to be really hard to stop those nosebleeds, okay? And another cause to some of these nosebleeds are hypertension, so high blood pressure. When people's blood pressure skyrockets, it's almost like a poppet valve that just exhumes the blood. That pressure's got to go somewhere. So the vessels right here are very sensitive. So that's probably the cause of it. So significance of external bleeding. So we know it's very serious, and we know that we need to stop it if there's a lot of blood. Now, if there's a little bit of blood, we're not so worried about, but a lot of blood we need to take care of quick. So look at that that number, 20% of the blood volume, the body can compensate and do okay. When it goes beyond that, not so much. It's a bad situation. So what do we see when we have significant blood loss? Increased heart rate, increased respiratory rate, and then a decrease in blood pressure. So remember, this is the compensation side of things. Your body is doing its absolute best to try to keep up with the blood loss. So all it knows to do is to increase the heart, to try to offset those decrease in blood pressure. Okay, so if we start seeing that decrease in blood pressure, that's starting to get to a late sign that you're in decompensation. It's a bad situation, especially if they become altered to the point of almost losing consciousness. No good. So what's funny is we can donate 1 unit, which is 500 milliliters of blood. So it's half of a liter, if you will, over about 15 or 20 minutes, and your body will make those red blood cells. I want you guys to tell me later where red blood cells are made if you don't already know. I'm going to ask you guys that question later. Okay, so if you don't know it, find it out, and I'm going to ask you and see what you guys say. All right, so your body will remake these red blood cells, and typically it's fine. Now, however, if you lose 500 milliliters of blood within just a couple of minutes or 4 minutes, your body ain't going to compensate, and it ain't going to make those red blood cells fast enough. So you're going to have some real issues. And think about your patients who are older in age. Their heart isn't going to function well, and those bleeding disorders on top of that. And even if they have pre-existing health problems, that's only going to accentuate all of those issues. Okay, it's going to be a bad situation. So here's some complications or serious conditions, with bleeding. So if you see the serious significant MOI, we've discussed that well. If they have a poor appearance, so if you come walking through that door, you're like, dang, that looks bad, it's probably going to be bad. Okay, so we need to go ahead and attack that person and do what we need to do, expedite them to the hospital, call for ALOS, do what you have to do to take care of that person. So look for them signs and symptoms of shock, and if there's significant blood loss, if there's rapid blood loss, big deal, right? Scary. And uncontrolled bleeding. Yes, there is a point, and there's places on the body where it is extremely difficult to control the bleeding, and we'll talk about those a little bit later. As I said before, arterial bleeding. So what you'll see with this is a spurt, okay? So every time the heart contracts, all that pressure is causing a spurt. So think about the heart, squeeze, spurt, squeeze, spurt. So that's what you see. You see basically their pulse as the heart is squeezing. So those are going to be a lot of pressure, so it's going to take a lot of pressure to be able to occlude that to stop the bleed, okay? What we normally see with this is bright red, calls it's oxygenated blood, is what we see most of the time, which makes the blood a little bit brighter. And then it also, like I said, it comes with the pulse. Venous, however, is more of a slow oozing. Okay, so it's bleeding, it's bleeding, but it ain't got that spurting. It's more of like just running off kind of quickly, but it's not spurting at all. These are a little bit easier to manage, so all we have to do is just apply direct pressure for a little bit of time, and typically we're able to resolve it. Just note that if you do have somebody that's on anticoagulants, so the blood thinners, those are going to be very difficult to control. You may have to hold pressure on those bleeds for a lot longer than what you would for a typical person. So just know that that is always a possibility. These are some crazy pictures right here, guys. This hockey player in the bottom right-hand corner, dang, I don't know what happened to him. I could only imagine that it was it was a skate to the neck, because that blood is coming out fairly quick. Now, if we were there to see it, if it was an artery, then it would be spurting, but hopefully it was just a jugular vein. Just know that arteries also lie deeper in the skin than the veins do. So veins are more prone to be nicked and to cut, as in comparison to the arteries, where they're deeper, and so it'd be more of a deeper cut. So remember your anatomy, physiology whenever you start looking at these things too. There you go. And capillary bleeds, so think about your abrasions. So it's going to be very, very slow. Even to the point where it's probably not even bleeding when you get to it. It could be even dried up. So clotting, as we said before, clotting happens within 10 minutes. So it's a pretty quick cascading effect. When the skin is broken, the blood flows pretty rapidly, and if the vessels are narrow, it reduces the bleeding, and then that excuse me, that clot starts forming. Okay, now bleeding will not stop until the clot is completely formed. So some things that's going to cause a deficiency with the clotting factors. The person's moving. This is why splinting is so important. If they have certain diseases, if they're on medications, we talked about the like blood thinners and stuff, it's going to be difficult. Removal of bandages. So when we apply direct pressure, we don't need to keep looking at it. What we need to do is apply pressure, and if it soaks through the gauze that we're applying pressure, then we need to put another gauze on it. We don't go and lift up, it's still bleeding, because what we're doing essentially is we're pulling the clot out every time we go to look at it. Okay, so don't do that. External environment, as I said before, if it's cold outside, the person isn't gonna clot like they should. As for the core temperature of the body, same way. And if it's a severe injury where say one of the members is completely severed, it's going to be very, very difficult to take care of that too, guys. So here's that hemophilia. So there are genetic issues. There's all kinds of different forms of hemophilia. I'm not going to go into all those, but basically what they lack is certain blood clotting factors. So normally a body has everything it needs, and it will do what it needs to do to take care of it. However, these patients may be lacking one of those components, which causes a huge issue when they start to bleed. So these patients need to get to the hospital very fast. They need to be seen really quickly, and there may be some medications that could be given in the hospital to offset their hemophilia. So these patients, we also worry about internal bleeding, such as gastrointestinal bleeding, where they could have an ulcer in their GI tract, and that could be causing a bleed, and they are defecating bright red blood. That's serious. That's once again a time to get them to the hospital as quick as possible. Talking about internal bleeding, since I discussed that, so bleeding that happens within the cavity of the body. So as I said, there are certain places like the abdominal cavity, the pelvis, the upper thighs, all those can hide a lot of blood, and you may not be able to see the distension and distension and maybe disfigurement of the area. It's possible that you could easily overlook this. So what we have to do is have that high index of suspicion, that MOI, that significant MOI in the back of our head. And as I said before, if I had a patient who they were driving a vehicle and their passenger is deceased, this is one of these exact reasons why I'm probably going to take them to the hospital emergency, because we don't know what is going on internally. They will need a CT scan and see exactly what's going on with their body. So some other things that can cause internal bleeding: a stomach ulcer, as I said before, talking about GI ulcers. Ulcer is a sore, if you will, for those with the medical terms. And it can be severe, or it can be kind of almost benign in a way, but it still causes pain and essentially it could bleed. Lacerated liver, as I said, very, very highly vascular. Also, spleen likewise. Broken bones also can bleed quite a lot, especially when we talk about the femur and stuff. And then you have the pelvic fractures, which can cause significant bleeding. We talked about high energy MOIs in our last slide. Or last lecture, I'm not gonna beat that one up, okay, guys? But remember your blunt and your penetrating traumas. Okay, those are both going to be a factor when we start talking about internal bleeding. There's the acronym. Pause the slide here and record this, okay? Make sure you know this one, because I assure you, when we start going through all of these scenarios, you are going to have to know each and every one of these. So DCAP, BTLS, deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, and swelling. Okay, so these are the things that we are looking for whenever we do our head-to-toe exam. The swelling, especially, and burns, it's more particular towards actual physical burns, but this still needs to be applied regardless when we start doing our head-to-toe exams. So as I said before, you can have internal bleeding and it not be to traumatic injuries. It could be all these. Now, we haven't talked about any of the pregnancy, the OB stuff, the obstetrics yet, but just to let you know, just for your own personal information, a ruptured ectopic pregnancy. So to quickly go through that, what we have in female gynecology is you have the ovaries on the outside, and then you have the fallopian tubes that connect it to the uterus. So whenever during the ovulation cycle, an egg is released and it goes into the fallopian tubes. And essentially, during consummation, what should happen is the sperm will meet the egg, and they should combine there in the fallopian tube. Now, if they do, then we essentially, through meiosis and mitosis and all the splitting of the cells, eventually will develop into an embryo. Now, that embryo is to float down the fallopian tube and attach into one of the sides of the uterus, to the uterine wall. Now, what happens sometimes is that that egg does not float down to the uterus, but rather it stays in the fallopian tube. Basically, what ectopic means is it outside of the norm, so outside of the uterus. So it could be outside of the fallopian tube, but not be attached to, but typically it attaches to the fallopian tube. And what happens is that can cause a tremendous amount of pain and a tremendous amount of blood. Okay, so I said all that just for that, okay? So a woman who is questionably pregnant, who is having abdominal pain and has lacked a menstrual cycle for a few weeks or for a couple of months, consider that they could, and with bright red vaginal bleeding, could be having an ectopic, ruptured ectopic pregnancy. Okay, something to consider. And aneurysms. Aneurysms are the swelling of the vessels, and it can get to the point where they actually burst. And when they do, it can be very fatal, very fast. And we'll talk about abdominal, the AAA, abdominal aorta aneurysm. Okay, those are bad. Very, very bad. So nature of illness, internal bleeding. So abdominal tenderness, guarding, rigidity, and also pain and distension. So this is when we're going to get out and we're going to palpate the quadrants. I'm going to stand up so you guys can see. So we start from the point where it doesn't hurt, right? So if it's hurting down here, we need to go away from it. And what we're doing is we're pressing on we should use 2 hands and kind of press. Is it soft? Soft and non-tender is what we're looking for, guys. That's what everybody should be. And if you have any of these right here when you're palpating, then there's room for concern. And remember, when you start palpating, the areas where you palpate may be indicative of what organ is being affected. So know which organ is in which quadrant. So you may have to go back through those again. Okay. So some other signs and symptoms that you may see, especially for older people, is dizziness, faintness, weakness. So what we call this is orthostatic hypotension. So orthostatic means kind of standing. So if you have them sitting or laying down and you take a blood pressure and say it's 120/70 and you get them to stand, and when they stand you take another blood pressure and it's 90/60, then they have orthostatic blood pressure. So it's, I believe, I'll have to look this up. I can't remember if it's 10 or 20 points difference. I'll have to get back with you guys. I'm sorry. Off the top of my head right now in this moment, I can't remember. But anyways, it's significant enough to have that orthostatic hypotension, which means that they're typically lost enough blood to where the blood is flowing downward and it's actually pulling up down to the lower part of their body instead of to their brain and chest. And ulcers and GI problems, you can vomit blood, okay? Hemaemesis is the name of it. And you can also have that bloody diarrhea or even bloody urine depending on where it's at. We can go on for days, talk about this. I'm trying not to bore you guys too much. Okay, signs and symptoms of internal bleeding: pain, swelling, distension, hematomas. We talked about that too. Dyspnea, so difficulty breathing, tachycardia, fast heart rate, hypotension, low blood pressure, and then you have your bruising there too. Melena, so this is also on the thing, so that is bloody stool. Okay, that's what that means, bloody stool. Yeah, hematemesis, there it is. I said hemaemesis, but it's hematemesis. Hematemesis, there we go. Broken ribs, bruises over the lower part of the ridge, rigid and distended abdomen. So other signs and symptoms. Hypoperfusion. Guys should know this one by now, what this looks like. If you don't know this, please study this slide really good and just burn this into your head, okay? So we need to know what hypotension looks like, or hypoperfusion looks like, and we need to know what the later signs of hypoperfusion looks like. So look at the difference here, guys. Your heart is trying to compensate the best it can in the later signs, tachycardic, and then you start getting that cool, moist, some people don't like moist, my significant other does not, clammy skin, vomiting, and another thing that you'll start seeing is that altered mental status, like something bad, or they could completely lose consciousness. That's always a possibility. Oh yeah, so here you go. Here's more stuff. Yeah, altered LOC. Pupils are dilated and maybe sluggish to light reactivity. Cap refill if it's under 2 seconds for infants and kids. We talked about that too. Feel the pulse, right, guys? This is where the circulation stuff in your slides are on your tables are really important. If it is a weak, rapid, thready pulse, then there could be some issues where they have a lack of blood going through their system. Their body's trying to do its best to compensate. Here we go. We know this. Beat a dead horse, right? This is what this is. We know our scene size up, right, guys? I'm not going to go too crazy. Just remember, scene safety goes throughout the whole call. It's not just your initial. Once you get on scene, you should never put the blinders on. Keep your surroundings open and realize what's going on around you. What's the NOI? What's the MOI? Remember the significance of each. Okay, so if it is a significant mechanism of injury, then we need to go ahead and take the spinal immobilization into play. We need to go ahead and take care of their spine, their cervical, and go ahead and put them on a long board. And we'll discuss all those things again and make sure you guys are comfortable with utilizing those that equipment. All right. Yes, and do not be so systematic in your approach that you overlook life threats. If you are systematic, you shouldn't. I should retract that. If you are doing as you're supposed to, you should not miss life threats. Okay, you should be able to tell ABCs, boom, 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 walking through. Oh wow, they are not breathing right. I need to assist their ventilations. Or oh man, they are bleeding profusely. I need to stop the bleed. Okay. Get a general impression. Okay. From a distance, you should be able to kind of tell that. Do they look like crud or do they look like they're doing okay? Always document in my narratives level of distress. So I say either they're an emotional level of distress or they show no signs of emotional distress or, I mean, no signs of distress. Those are always big. If they have their eyes are open and they are hyperventilating or whatever have you, that I have to document that. Okay, that tells me exactly what's going on. I like to paint a picture to my readers. Be aware of obvious signs of injury. Excuse me. Rapid exam. So we'll talk about this. I wish we could have done this in class. I gotta show you guys. I'm sorry, it's hard. But the head to toe. So you look from the top of the head down to the feet, and you assess all the things within just about a minute or two. You should have that down really quick. Determine level of consciousness. We can ask them those A and O questions: person, place, time, and event. And if they are alert and oriented to all four of those, then they are good to go. If there's any change to that, then there's room for concern. Okay. Airway breathing. We know this already, guys. Patent airways, remember how we check that? We ask them a series of questions. If they're able to talk back to us in complete sentences, patent airway. Verbalize this or vocalize this whenever we go through the scenarios, so we know that you are assessing it, okay? Because it's going to be hard in pretend world of scenarios unless you actually tell us, well, they're speaking, therefore they have a patent airway. It's good to know. Adequate breathing. So is it shallow? Is it deep? Is it fast? Is it slow? Are they showing like Cheyenne-Stokes or apneic, opportunistic? All those are room for concern. Okay. Check breathing sounds, breath sounds. Remember, an absent lung or an absent lung is a dangerous lung. So they should have clear bilateral lung sounds, and you should do at least 4 fields, right? Up here, and then down here. Whoop, here we go. Down here and over here. Okay, guys. If you do posterior, the back, you can do it in 6 different auscultations. Remember to bounce from one side to the other when you do it, so you can comparatively go and see how one side is to the other. High flow, assist ventilations if necessary. So remember, if they are in shock, they need oxygen. Okay, administer oxygen. I would suggest a high flow non-rebreather would be best, 10 or 15, because obviously their body's not perfusing like it's supposed to. If you need to, if the person is unconscious, we can insert an OPA. Remember, OPA checks the gag reflex also, so that'll make us aware whether or not they have that intact in case we need to utilize something other than an OPA, such as a King airway or one of those blind insertion airway devices. You can also put an MPA. You can put that in nasopharyngeal airway. You can put it in a conscious patient. So just something to consider. Circulation. Remember all this stuff, guys. I've talked about this a lot. I'm sorry. I know you guys probably know what I mean. So pulse rate, quality, skin color, condition, and temperature. So cap refill. Like I said, that's better for pediatrics mostly. If there's any external bleeding, we need to take care of that immediately. And treat for shock. Keep them warm. Give them oxygen. Okay. Stop the bleed. So from there, we should be able to make our transport decision. So look at your forms, guys, even right at this moment, and just look how everything is laid out. All this is that systematic approach. We've done our ABCs, now we're moving to our transport decision. So if anytime there's a life threat or a potential life threat, expedite, okay? Get them out, take them to the hospital as quick as possible. If there are any threats to their ABCs, expedite, get them to the hospital. So here's some signs and symptoms that would constitute a rapid transport. So take tachycardia with other symptoms. I can't just say that by itself is enough. If these were all together, I would say it would be a better line to run up with. So low blood pressure, tachycardia, weak pulse, and clammy skin. All those. History taking, if you're able to. If you once you understand what the chief complaint is, what the patient perceives as chief complaint, then you can start doing your investigation, right? Put on the old investigator hat and you can start looking into it. So are there other signs and symptoms, other injuries that are due to the NOI or MOI? Is there any obvious signs of an internal bleeding, swelling, discoloration? Those could mean there's something going on, and then we need to assess the entire patient. So this goes with the D and E. So you've heard of A, B, and C. There's also a D and E. So D is deformities and E is exposure. So with our traumatic patients, we don't need to be shy about taking their clothes off, okay? We should have some shears to take off their clothes, cut their pants, cut their shirt off, and we need to look at them thoroughly, okay? Sample history always should be taken if you're able. Now listen, I told my group the other day, you may get stuck in just assessing life threats and taking care of ABCs. That happens. You may never get into the sample history. That is a complete possibility. You may never get out of the primary survey. You might be stuck solely there the whole time. The secondary assessment stuff may never happen. It's possible. Blood thinning medications, as I said before, is a big deal. Do they have history of that hemophilia or blood clotting disorders? Good to know. Medical alert tags or bracelets, pendants, look for those things. Bystanders are always good help, okay, most of the time. How much blood loss? That's hard to determine, guys. If anybody's ever dropped any liquid on the ground, especially like milk, you can pour out a quarter, like 2 cups of milk, and it looks like you just dropped the whole gallon. So it's very hard to determine the amount of blood loss. We can say that there's a pretty big pool of blood, and you can take a shot in the dark about it, but it's very hard to determine, I assure you. So there's your secondary assessment. So this is when we get to the more detailed stuff. So we do the vital signs, we start using our tools. We start doing a focus assessment on the pain, so we can go and start palpating that area, look at it. We can attach monitoring devices. And like I said, there it is in black and, well, white and blue. That transport time, you may not be able to do the secondary assessment. It's a possibility. So all the whole body, you should be using the acronym DCAP-VTLS. So look at the scalp, the forehead. You should also be feeling the quadrants in the stomach, or the abdomen. I say stomach is a bad term. You should record the pulse, motor, the sensory function of the extremities. So all of our distal extremities, make sure that the fingers are working, toes are able to curl. Got a good pulse, radial pulse right here. Likewise, a pedal pulse on the feet. We'll show you guys how to find that. Some people don't like feet, but got gloves on. Hopefully it's okay. So vital signs will help you kind of determine how bad the patient is off. So if they have a systolic blood pressure less than 100, well, this says 100, we say 90. The book says 100. 90 is actually the truth. And they have a rapid radial pulse, then that is suggested of the presence of hypoperfusion. Okay. Cool, moist skin, gray is also an important sign. Shunting of blood, we talked about that. So reassessment. So an unstable patient, you guys know this. I asked you this probably the first day we're together. Every 5 minutes we assess the vitals. If they are stable, 15. I like to use 10. I just like that better, just because I feel like I get a better view of them. 15 seems like a very long period of time. But yeah, keep tabs on these patients and check them out. Okay, guys. High flow oxygen. Control the bleed, and then provide measurements, treatments for shock. As I said, keep them warm, okay, guys? Keep them warm as much as possible. And don't sit on scene. Get them to the hospital. This says recognize, estimate, and report. Do the best you can, guys. It may not be completely accurate, but if you can say 200 milliliters of fluid, and you just remember that's I don't really know how really to tell you guys. So a liter bottle of fluid. So that's, if you go pick up a 1 liter, and it's a big bottle. It's huge. So, that big, that's a lot of fluid. It really is. So if you can kind of gauge it off of how big that bottle is, maybe you can be able to make a good estimate. And tell the hospital we need to call them up before we get to the hospital. We're going to get you guys proficient in calling in radio reports, because that's a part of our job, is to communicate with the hospital and let them know what we got. And we need to document, as we should with all of our injuries, what care we provided and how the patient responded to them. So foremost, when we start controlling the bleed, the biggest thing that we have to be aware about is we have to take standard precautions. We have to have that proper protection equipment to be able to take care of these patients. This could mean wearing gloves, eye protection, and even a mask or gown if necessary. Be sure, once again, that the patient has a good open airway, and provide high flow oxygen, and then control the obvious bleeds, okay? If they're life-threatening, arrest them quick. So the easiest way to control external bleeding is direct, even pressure. You can use pressure dressings or splints. John will talk to you guys about that next Thursday. And tourniquets. I love tourniquets. Tourniquets are great in extremities. They don't work so good on the neck. We shouldn't be using them on the neck. And junctional places. So when I say junctional, I'm talking about like where the neck kind of comes to like these points right here where it's very difficult to apply pressure. Say like here in the axillary area and the armpit and such. It's very difficult to control those bleeds. Think about your groin also. That's very difficult. They have junctional tourniquets, and they are fairly effective. But in those situations, you should apply direct pressure techniques. Okay. This is the most efficient way. Don't be afraid to apply a decent amount of force, especially in junctional areas, with the exception of your neck. Those are going to be issues that we don't want to occlude this airway. If we do that, we could potentially kill the person. Okay. But we have to save their life, right? So it's life over limb in those situations. So with some of these, it can take up to 5 minutes, even longer if they're on anticoagulant therapy. So we need to just keep holding that, and as it says there, uninterrupted. That is the key word. Do not lift up. So what kind of pressure dressings do we have? So a 4x4, meaning 4 inches by 4 inches. It's a square about yay big. That works very well for most wounds. We do have larger dressings that can be applied. We'll talk about abdominal pads and such, which are about 6 inches by 9 inches. And they have even bigger ones than that for your big stuff. So the dressing should stretch across and control the bleeding. However, you do not make the pressure dressing too tight. If you do, you could potentially cut off the blood flow. So it should be enough pressure to control the bleed without cutting off circulation. Okay. And do not remove it until we get to the hospital. If my first responders have applied a dressing and it works well, I'm not going to go and cut it off to look at it. I will ask them the details of it, and then I'll correlate that to the hospital. I believe that if it's good enough to stop that bleed, I am not going to touch it. Okay, so consider that for the future if you guys start working as first responders or working as EMTs and furthermore. Hemostatic agents, these are awesome. Golly, man. Celox is typically the name for them. So these are chemical compounds. They're typically kind of clay-based. It's kind of weird. So they emulsify these gauze in like this compound, and whenever it is applied into blood, it helps the clotting cascade to take effect. So it has this pretty cool chemical reaction and stops the bleed pretty quick. So John will talk about how to pack the wounds, especially with this hemostatic agent, and it is fantastic. It works very, very efficiently. So think about those junctional areas. Like I said, you can even use them here in near the neck. If they have a laceration, that's completely fine. The probability of an embolism is pretty low if you use those hemostatic agents. Tourniquets are fantastic. That's the other thing I really love. They are efficient and very effective if used properly. So they have to be at least 2 inches in width. Some of these, like these devices, where they have a high fail rate if you have to utilize like a triangular bandage, they have a tendency to not work as well as per se a commercial device. So we'll talk about that. The fail rate for those are typically about 70%, so 30% of the time they actually work. So it's give or take, right? So do not apply it directly over joint. So if you have a cut, say here, don't apply it here at the elbow. Or likewise, if the wrist or the hand is bleeding, don't apply it at the wrist. It has to be against some type of a bone. So essentially what we're doing is inside we have our bone and we have our vessel. So we're compressing the tissue down to where the vessel and the bone kind of collapse, or the vessel collapses against the bone. So that's essentially what you're trying to do, is squeeze it so tight that the vessel actually is blocked off. Okay, so you should always go proximal or above the injury. The way that I've always been trained, and I'll tell you guys the same way, is high and tight. So go as high up into it as you possibly can. That way, if that one doesn't work, you can slide another one on there and apply another tourniquet. That's the way that I prefer to do it. Like it says there, it has to be about 2 inches wide to be able to be effective. Never place any padding. Okay, it's going to hurt. Hurts like a mother. I don't know if John's going to actually get you guys to put it on. I hope he does, because you guys should feel how much tension it takes to stop your pulse for a minute. It's a lot. Yes, and do not loosen it, guys. Once it's tight, don't loosen it up. Keep it on there. There's a lot of studies out there for military that they can be left on a patient for up to 14 hours. So it can go on for quite a while before it does any neurological damage. So don't touch them. Leave them on there. What I would suggest to you guys is when John talks about them, there's going to be a tag that folds over right the time that you put it on. Okay, that way the hospital is aware. They know about how long before there could be potential damage to the tissues or to the functionality of the limb. Air splints we don't use. Let me tell you why we don't use them. There's not really a good picture there, but you have to blow them things up, okay? So could you imagine somebody bleeding out and you're down there about the same level with that splint trying to blow up a piece of PVC elastic? That's not good. So we typically don't use them. However, they're still out there. So if you just admire the photo there, kind of gives you a sense of what it is. The idea sound, I mean, some of them do come with a hand pump, and those are the best ways to do it. But what it does is it expands to the point where it immobilizes the joint, which is which is great, or the arm, the extremity, which is great. It works very well. But once again, it's questionable if you have to actually blow it up by your own personal math. It's not so much. So typically what we do use is these rigid splints, and these are good to immobilize the fractures. John will go through these with you guys, and typically we will tie it off in a couple of different locations to keep the limb straight and keep it from further damage and further pain. So those are great items. They really are, and he'll talk about those and go through them with you. So what do we do whenever we had some bleeding from your mouth, nose, or ears? So some conditions can contribute to this. Of course, skull fractures, mandible fractures, maxillary fractures. Those facial injuries can be bad. You can have even some infections, dry cracked mucosa. We know that nosebleeds, high blood pressure. We talked about that. Digital trauma, so if something happens, digital trauma, that's what's talked to, or the nose or the ears. Coagulation disorders too. Nosebleed, talked about this, guys. So I think this might be on the study guide. We don't do this, right? Don't do this. Okay, they should be leaning forward, and pressure here. A cold pack actually helps to slow the bleeding down too. So cold pack on the forehead right here, and then pinching and leaning forward. Okay, that's the position that you do. Guess what happens when we swallow blood? Stomach don't like that. Stomach will vomit that back up. So never tell somebody to tilt their head back, because they're going to vomit that thing up quick. So lean forward. If by chance it goes back, then hopefully it'll just come out of the mouth instead of going back into the esophagus and then down into the stomach. Know this, guys, that whenever we're doing our assessment, we're looking at the nose, mouth, and also the ears. If you have bleeding at the ears or the nose, there is a potential that could be a skull fracture. We'll talk here at the very end about how you can possibly determine whether it's to do with a skull fracture. These situations are very difficult to control because there's no way to really truly access it, at least with us. The best you do is just kind of put a loose bandage over top of it. If you do try to, well, it says do not stop the blood flow. The biggest reason is that you don't want to clot up and potentially do damage to like the eardrum and such. So we should apply a light compression. So here we go. I think this might be the last slide, guys. So this is called the halo test. So if you can see there, CSF, cerebral spinal fluid, has this kind of yellow, hay-looking coloration. So if you see on the very outside of where the blood drop is, you'll kind of see that there's this yellow color. So this is what they call the halo test. So if you're able to get that 4x4 dressing and kind of get a drop of blood, and if there is that yellow coloration that comes out after it starts spreading, that is I think it's about a 30 or 40% probability that they have a skull fracture that is leaking cerebral spinal fluid. So that's a bad situation. Once again, more of a reason to get them to the hospital fast. Okay. I told you wrong. There's more slides. My bad. Okay. So we know that internal bleeding is something that we can't really do much with. However, we can try to reassure the patient the best of our ability. Say, listen, we're taking the best care we can with you. We're going to give you this. We're going to give you some oxygen. We're going to maintain your body temperature, as it says there, by placing a blanket or a heated blanket over top of them. It says splint the injured extremity. You know, if it is an extremity, of course, we're gonna do that too. Look for the swelling, deformities. Those are going to be a clear indication. Typically, we don't know if it's broke, but if it's angulated, if it's at a weird kind of bend, then we may be considered, of course, that they have a fracture. There it is. There's the last one. All right. Look at this, guys. See if you know what this one is. Whew. Thanks for being patient with me, guys. Give you a second or two. There you go. All right. So includes the heart, the vessels, and the blood. Of course, respiratory. Now, if it said cardiopulmonary, then yeah, you could throw that in there, but it says cardiovascular. So you guys should know this one. I'm sure you do. It is C. So perfusion is the circulation of blood within an organ tissue, and carbon dioxide is a byproduct, and it should be removed. All right, guys. Once again, you don't have to do this last one. So questions, comments, concerns about anything, please get in contact with me. And like I said, I'll post the quiz is going to be on both. So I'll be sure it's somewhere where it's very accessible, probably within chapter 25 slot there. So you guys will be able to see that. But have a good weekend, and y'all take care. If you can, get that quiz done by next Tuesday. So I'll give you all weekend to work on it, which shouldn't be an issue. I'm shooting for about 20 questions. If you have any problems with that, please let me know, and we will see you guys on Tuesday. All right, y'all take care. Bye.